Welcome, everyone, to our panel discussion on AED technologies. We have several people joining us for today's conversation. We have Tom Bouthillet, Battalion Chief of EMS at Hilton Head Fire Department. We have Justin Hurzeler from Zoll Medical, where he's a clinical support specialist. Joining us from Ridgefield, Connecticut is Rommie Duckworth. We have David Blevins here in Knoxville, Tennessee at Roane Community College, and John Todaro from Eagle Emergency Consultants down in Florida. So thank you all for being here. One of the things that I wanted to bring up with regard to AEDs is, I see generally two flavors. There's the AEDs used by professional rescuers and the AEDs that are used by the general public. But I want to talk first a little bit about the ones used by EMS response professionals. Could also include, fire crews, police officers, those sorts of things. But with regard to those types of AEDs, are there any particular issues that you've run into with seeing your colleagues using those devices in their respective response vehicles? Any particular problems or technology issues that you've encountered?
Yeah, I'll jump in here. It's Justin from San Francisco. One of the big things that I've seen on the public safety side of AED use anyway is specifically with law enforcement and when to apply the defibrillator. One of the issues we had in their training was trying to reinforce that if the machine says no shock advised, that doesn't mean it's broken and to go get another one. And that's an issue we've seen a couple of times. But the best things about the ones that they're using, they are compact. They've got a fantastic battery life. They can live in the back of the patrol car for a year and a half before they need to be addressed. And being able to have that kind of technology in the police car to get there first is a great benefit.
Do you find that when it's being stored in the trunk of the law enforcement vehicles, that the battery life seems to decrease with the perhaps increased exposure to heat? I know it's not real hot in San Francisco last week, not counting, but has that been any sort of an issue for you and anybody else on the panel?
Yeah, not that we've noticed so far in our agency, no.
Okay. And Justin Hurzeler, speaking from a Zoll perspective, is this an issue that people need to be concerned of? Is extremes of temperature with AED exposure that you're aware of?
Not that I'm aware of.
Okay.
I would add on to what Justin Schorr said and say that there were a couple issues that I saw when I was in the field. The first and probably most important one being ability to transition between agencies. So if you have one fire crew who shows up, applies an AED, and then an ALS crew shows up and they have completely different technologies, suddenly we're changing out pads, all of those things, that continues to be an issue, I think, throughout the field. And then the other issue that I've seen in the past is that not all AEDs will record data from the call in progress. And so if your department is aggregating data, reviewing calls, things like that, that can be an issue for sure.
Yeah, I think particularly across manufacturers. So if the first responder has brand A and the law enforcement officer that may have gotten on scene, he might have had something different, a public access defibrillator, another brand, the ambulance crew, another brand, certainly even further compounds not only the data aggregation challenge, but also the issue of pads and cabling. And one of the things I ran into in one of the places I worked was that sometimes law enforcement, more so than the fire departments, I think, they would be willing to put on the AEDs, but they weren't necessarily doing CPR. Has that been an issue in any of your communities where they just used the AED, but they weren't doing CPR in conjunction with the AED application?
Yes, we ran into that a little bit, and I think that sort of builds on what Justin already mentioned, sort of a not a misunderstanding and maybe a lack of follow-up training. And we had the experience rolling out AEDs with our colleagues in the police department. My department is a combined fire EMS agency, but also rolling out AEDs through another grant throughout the rest of our community and a lot of the public spaces. And what we didn't realize at the time was that we didn't have inadequate infrastructure and an inadequate part of the grant supporting the education to really help people, the general public, the people working at these facilities, in our case, we're town employees, as well as the police department, to really understand those components. Things like Justin said, that if the machine says no shock advised, it doesn't mean anybody did anything wrong. And it certainly doesn't mean that the machine failed, exactly as he said. And likewise, that CPR is the essential component and how that needs to be integrated with AED. The kinds of things that we understand well, and certainly, does get taught, hopefully in regular classes, but we underestimated the need for education and how much education needed to be rolled out, so that it wasn't just the AED product, but it was an entire program that really helped the community. And we're still in the process of ramping that up.
And Rommie makes a good point. I think one of the weakest things that we see, especially with non-EMS public safety AED programs, to get an initial education, the AED gets put in the car or the cruiser or wherever it's going, and it's forgotten about. And if they go on a call and they remember, they pull it out. There's not repetitive training. There's not the opportunity every quarter, to bring it in and not only just do the training with the personnel, but also check the equipment. Are the pads in date? Are the batteries functional? Do they need to be changed out? And having a system to change out pads and batteries when they expire or when they die is pretty difficult in some places, because it is a little bit of a financial burden. It takes some time. It takes some money. And agencies don't necessarily think about that when they get the grant or they get the free AEDs from some local community organization. Don't think about that maintenance and how they're going to maintain their staff, how they're going to maintain that equipment.
Yeah, because it is under the operational control of different agency. I mean, it's hard enough sometimes to make sure your own equipment is getting properly checked and maintained, much less someone else's. But given that it's a piece of medical equipment, sometimes law enforcement, I think, may have a little bit of a tendency to kind of rely upon EMS for those sorts of support services. Tom, in your community, for example, does the law enforcement agencies maintain and do their own equipment checks with the AEDs, or is that something that the fire department does to help their law enforcement colleagues?
It's been a struggle with the county law enforcement here to adopt AEDs. They've been resistant. They perceive that they're cops, not medical people, and yet they provide naloxone. So all of a sudden, that's been a kind of a head scratcher there. But we do have a lot of private security forces in our gated communities around the island, and we've been very successful getting AEDs into those communities. What has been a greater challenge is, especially in residential areas, how do they know that the AED is needed nearby? We have one of our gated communities that's monitoring our dispatch channel. So if they hear us dispatch a call in their jurisdiction, they will respond right away. They always arrive a few minutes before us, and they do a really great job. In many of the other gated communities, they don't have a trunked Motorola radio that monitors our dispatch frequencies. And so we've explored other technologies to alert them when help is needed. And we like to think of this as different layers of protection. Just like the room that I'm sitting in here now, it has fire rated sheetrock on the wall. It has a smoke detector. It also has a sprinkler. So can we build them a web-based portal where they can see those calls popping up on a screen? Can we get them a radio so that they can hear it go out if their head is turned? And is there smartphone-based applications that we could give them a push notification? So we're looking at all these different ways to help connect the AED with the person that needs the help, because the job's not done until the shock's delivered, in my opinion. And so we're trying to just kind of get these interconnections in our chain of survival and fine tune it that way.
Come back to some of those interconnectivity issues in a moment. But before we leave this issue of law enforcement participation in AED programs, David Blevins, could you comment a little bit about what your observations are as an EMS educator? I'm sure you get law enforcement folks into your EMT classes, et cetera. do you see any cultural issues with law enforcement with this notion of, they're law enforcement, not medical, and, just some of those rubs that seem to get in the way sometimes?
Well, in our region, and I want to thank Tom for his comment, because I think it's starting to see a lot of shift with the focus on overdose and the administration of naloxone. There's a lot of individuals that are starting to get that, hey, I'm going to be there for a couple of minutes before that first response agency or the transport organizations are getting there. So they're getting some additional buy-in from the advancement. So the push around here has been to provide those opportunities, and what we're seeing is some of the same things that everybody else has mentioned. The educational side of when to use, understanding the cues that most of us know, such as the no shock advised, it's not a broken device. And, just because the fire truck or the ambulance shows up, that's not a good time to stop. Wait to integrate that move. So getting to those a little bit more deeper, that where the efficacy or the efficiency and effectiveness of CPR and AED use become beneficial. The adoption is being pushed greatly by some of these expansions of care from those law enforcement agencies at the beginning.
Well, training has been something that we've been talking about a lot throughout all of these issues. In your respective jurisdictions, are you observing where law enforcement is invited to participate, say, on pit crew style CPR training exercises, crew resource management, whatever term you want to use, but the choreograph of resuscitation scene? Is law enforcement being invited to participate on any of those exercises? And I'll start with you, Rommie.
We had a change in leadership at our police department just at the beginning of COVID, and we're lucky enough to have a new police chief in our community who wanted a much closer relationship between fire and law enforcement. We've always had a pretty good one on the street, but in terms of putting together programs like this where we could invite law enforcement in to be an integral part of this training, which only makes sense because they are first responders for us. And unfortunately for us, that was completely derailed by COVID and everyone needing to isolate, is the exact opposite of how we needed to literally have everyone in the same room. But now that things are opening back up again, I'm really excited to be able to bring our law enforcement partners on board, and not only the leadership to say, yes, this needs to be an ongoing part of the resuscitation in the community and the AEDs that you have in the cruisers, but you need to understand how some of what we do, especially at the advanced life support level, really counts on what you're doing in those first few moments.
Justin Hurzeler, how about in the communities that you've been working with, not necessarily as a Zoll representative, but in your clinical experience, have you been seeing law enforcement drilling with the primary EMS providers on cardiac arrest scenes?
No, I would say that I was fortunate to work with some really excellent law enforcement agencies throughout Central Texas and also in the rest of the state. And they had some great administration who were very cognizant of the necessity for that training. But I think we all know that it's always a challenge at the administrative level to get departments to integrate together and train together and find ways to mutually support in that way. And I also think that there's quite possibly a level of at least subconscious resistance among providers, medical providers, to suddenly grab somebody that they've never worked with before in that capacity and try to integrate them into a pit crew model. I think that would take some adjustments in perspective for some people. Yeah,
and that was kind of my point. How about you, Justin Schorr? How does it work out in your area of California? Do you see any of those sorts of activities?
We do, actually. I had the opportunity to work with a much smaller community at one of our large regional airports, and the law enforcement officers were always quick to respond. We had the opportunity to actually walk them through the purchasing process and make sure that they not only got a lot of the things that we're talking about, a compatible model, so that we would be able to leave the pads in place and directly connect our equipment. But most importantly, and I think it was Justin that mentioned this technology earlier, the ability for that device to not only record what it saw, but for us to be able to download it after the incident. And there were many times where we would not only get pulses back, but the patient would regain consciousness prior to the hospital. And the hospital wouldn't believe that they were in VFib or that CPR had been done. But when I hit the door with a printout that shows, hey, look, they were in VFib, it was good CPR, we shocked it and it worked, it changes the entire mindset of the clinical care moving forward. So making sure that we not only train with them as best we can, but guide them through the purchasing process, that's going to make the biggest difference, in my opinion.
You know, one of the things we've been talking about thematically is not so much about the technology itself, but the implementation of that technology. And, you know, one of the crucial issues with AEDs is being able to get them on patients when they need to be put on patients. And sometimes communities don't know where their AEDs are. So, you know, let me start with you again, Rom. Are there any programs that you have in place in your community or in other communities that you've worked with on how they have gone about the task of trying to map their AEDs, and has that been successful? You know, what works, what doesn't work in your experience with that?
For my own community and some of the surrounding communities, we really have been working on mapping the AEDs so that there's a public expectation that, at least for any public building, they know that there are going to be AEDs in several sections of that public building so they're easily accessible. What I hope to be able to do one day, and that has been a part of some of the communities around ours, some larger communities, is actually have social media or app, mobile app integration, so that people who are CPR certified, and this becomes part of their training that's rolled out locally, will be able to be alerted not only if there's an incident in progress, maybe right around the corner that they wouldn't otherwise know about, that they could help with CPR, but also where the nearest AED is, to really bring all of those forces together.
But you haven't implemented that yet, if I understand correctly.
That's correct. I'm hoping that we're able to do that in the future, but for right now, we're a little more pragmatic, and what we're focusing on is making sure that AEDs are working and available with at least some trained public lay people, and community employees that know where they are in every public building in our community. So that's just going to be an open expectation for those residents and visitors to our community.
Yeah, great place to start. So let me shift to Tom. Tom, you literally are on an island, so it's a little bit more of a defined area to work with. What's been the experience on Hilton Head Island with trying to find out where all of the AEDs are? How did you go about that very challenging exercise?
Well, about half the AEDs in the community, we facilitated putting them in place. So we're aware of about 215 AEDs on Hilton Head Island. We've placed over 100 of them through the town's AED program. And then the others that we have either found along the way, or now they're actually required when they place an AED to fill out a form and send it to us, that we enter into our AED registry. So we have them well mapped. We have them in a GIS layer, so our 911 telecommunicators can see them on the CAD map when the call comes in. But overall, I want to emphasize that this has not been sufficient. So we have data on Hilton Head and, frankly, the CARES registry. In the United States, AEDs are frequently nearby and they are seldom used. So we have not done enough to improve the situational awareness of the AED operator who's trained to the fact that there is a need nearby, and that for the AED to actually be used prior to the arrival of EMS. So this is kind of an open challenge of not just, where your AEDs are we sure that the battery works? Do we know that the pads are okay? Does our 911 telecommunicator know where they are? But have we done enough? Have we done enough so that the person that knows how to operate the AED is notified in such a timely manner that they have an opportunity to respond and use the device? And I would argue that we have not sufficiently tackled that problem in the United States.
Yeah, there are a few places that have, I have no connection to this department that I'm going to talk about. It's just, they fascinate me. And that's the Villages Department of Public Safety, which the Villages, for those that don't know, is one of the largest retirement communities in the United States. And they have a rather unique system. They have a nonprofit AED support foundation that was founded by a community member that is linked to the fire department communication center through a smartphone app system. I actually don't even know which one they use. And they have several hundred AEDs in public buildings, in buildings owned by the housing district that the villages is comprised of, as well as individual homes. And when they get a call, their dispatch center can tell where the nearest AED is, and they can clip out that person on their smartphone and have them respond. And that private foundation keeps up the equipment, helps the fire department maintain the GIS coordinates and all of that for where those are, as well as assures that the people who have the AEDs are continuing their training, continuing their CPR training. And as a result of that, their cardiac survival rate in the villages has done very well because of this program. And this is a citizen-based program that was brought to the fire department. A group of concerned citizens said, we want AEDs. How do we go about it? And they felt they could control it and buy more and get more donations if it was a nonprofit foundation rather than a government quote agency. So they've done very well with it. I know that they're happy to share with anybody who has any ideas that they'd like to know how they're doing it. I know they'd be happy to do that. Chief Kane, who is the chief of public safety of the fire department there, Edmund Kane, I'm sure would be happy to share that information with anyone.
Is that in Florida, John?
It is. It's in Florida. It's in Central Florida.
Thank you.
Now, Justin Schorr, you're in a big metro area, and sometimes, that sort of thing might not scale in that regard. But one of the things I'm curious about is your perspective on a project that was done several years ago in Philadelphia, where they actually had a scavenger hunt with the public to try to find AEDs. Do you think that would be a workable strategy in the San Francisco Bay Area, or are big cities just going to be a harder nut to crack?
It's going to be a little bit more difficult in the larger cities, but with these communities, much like we were just talking about in Florida, we have our separate neighborhoods that are around, so we can have volunteers go through those areas and identify them for us. When I was working at the airport, we had the opportunity to send out interns who would scour through, and of course, we kept meticulous records as to where all 136 defibrillators were located. We really wanted to put them on an app-based service, but one of the issues we ran into, and Tom might see this with some of his gated communities, is the app will tell someone where a defibrillator is, and then they go into a secure area without knowing it, and now all sorts of other problems come in. But moving back out into the urban area in the larger cities, San Jose, San Francisco, Oakland, it is going to be difficult to do that. But one of those app-based services was developed right here in San Ramon Valley Fire, where a fire chief was sitting having lunch, and one of his rigs pulls up code 3, and there's a cardiac arrest in the hairdressers next door. He could have been there. He's got a defib in his trunk, could have been in there doing ALS care right away, and it wasn't something that was available. So being able to find these public access defibrillators, being able to put them in some sort of format that the public can interact with is going to be huge, absolutely huge. But figuring out the way to do it where it's accurate, we can keep it up to date, is going to be a struggle for some departments that don't have that budget.
So let me shift a little bit more back towards the technology end of things and away from implementation. Are there any features that you think would be useful to have on AEDs that maybe aren't commonly there now that might assist with some of these challenges? And I'm going to start with you, Tom. I know that you kind of work with some of the technology companies. Again, without getting into the names of any particular brands or products, what sort of stuff are you seeing companies starting to work on that might help with some of these issues?
Right. Thanks, Mick. So I think everyone remembers like 5 years ago when everyone was talking about the Internet of Things, and it was going to be this like super important thing. And you're sitting there going, I don't know if it's important for my refrigerator to know that I'm out of milk. I'll just decide that on my own. One area where I think is going to have a tremendous improvement with automatic defibrillators is a future of connected devices that not only do we know where they are because we can log in and see them because they're connected, but they know where they are. And so they can report to us in real time, what is their battery life? What is their temperature? How close are they to the event? I'm imagining a device that can automatically upload case review data in a non-proprietary way so that you can do your post-event review from home, and maybe even transmit it into the patient care report and things like that. So I think the idea that we have to find the AEDs, where are they? And then we have to inspect them to find out if the battery's okay, and we have to check the pads. All those problems in the future with a connected device should kind of go away, and it should be easier for us to kind of use the data, leverage that data, because I think it was Justin that mentioned that not all devices even capture the data. But that could be the difference of whether or not somebody gets an implantable cardioverter defibrillator. That could like determine whether or not, as Justin said, whether or not the emergency physician really believes that that patient that was in dialysis and lost consciousness was shocked by the AED, but they think now, well, maybe it was just rapid AFib or something like that. There is no substitute for actually having the ECG showing the waveform, showing the VFib, showing the shock for the patient's downstream care. So I'm hoping that what becomes routine in the future is our jobs get a lot easier because we leverage modern technology in innovative ways like that.
Yeah, and Dr. Cheskes wasn't able to join us today, but he gave the State of the Technology talk on AEDs. And one of the things he mentioned that he frequently gets calls about as the medical director for Toronto EMS is calls from the electrophysiologist wanting to see those tracings so that, just as you mentioned, Tom, what was the rhythm leading up to the arrest, whether it was witnessed by EMS or perhaps the person was unconscious before they went and arrest, but maybe that AED captured, some of the pre-arrest or post-arrest rhythms to give clues, what the underlying electrophysiology problem was that resulted in a cardiac arrest. So, yeah, very significant there. Let me shift over to Justin Hurzeler. So, in your experience, working on the supplier side of all of this, Justin, what sort of things do you commonly see that AED customers struggle with? And if you can maybe look at that from two perspectives. One is your professional clients, EMS, fire, law enforcement agencies, public safety agencies, if you will, that they've struggled with in trying to get their technology to work as designed, as intended. And then perhaps on the public side, where those same public agencies often have a significant role in getting this stuff out to the public. If you could comment from more of the supplier side of this.
Well, Mick, I would hesitate to throw a roadblock to that question, but honestly, I'm not in sales or supply. I'm strictly a clinician when it comes to these things. So most of my encounters with the people who have bought AEDs comes on the back end, usually in terms of reviewing case review data, that kind of thing. I would say that, the two biggest drawbacks I see overall in AED technology is not, well, for example, not that long ago, all of us in EMS thought that we were doing great CPR all the time. And then data recording was invented, feedback was implemented, and we found out we were really, really wrong about that, right? So I would like to see CPR feedback be pretty universal to all AEDs, so that even at the private citizen level, they were getting instantaneous feedback and coaching throughout the call. I think that would be invaluable. And then the other thing that I think is really important is narrowing that pause time for defibrillation as much as possible. So implementing rapid shock technology or whatever technology it is for that particular AED brand, and improving the algorithms there so that, the AED can be analyzing before we ever even come off the chest.
Yeah, the Parry shock pause issue, particularly with public access defibrillators, can be lengthy. Have any of the other agencies represented on this call had an experience with trying to coach your professional rescuer colleagues that are using AEDs on how to reduce the peri-shock pause, sometimes in spite of the verbal prompts from the device.
Definitely. So, Mick, this is one of the things that they teach in the Seattle King County Resuscitation Academy, but it is device specific. So, you know, for example, one particular device, when you're ready for the analysis, as soon as it decides a shock is required and you hear the capacitor start charging, you can resume chest compressions during the charging. And so they teach to do another 30 compressions. So you're building up that coronary perfusion pressure again, and then you can stop, deliver the shock, and get right back on the chest. So you're really off the chest just during the analysis. And I know that other types of AEDs, and maybe they all do now, they just pre-charge the capacitor and assume that you are going to eventually need a shock. So that eliminates that entire charge up phase. So I do think that the companies are aware of this issue. And I think they're taking steps to try and minimize that. And I think that's good for everybody. I want to mention one thing that I forgot to mention before, and it's so basic, and that is AEDs that have the correct time and date, so that we can match it up with the rest of the timelines going on with the rest of the call. Even our main cardiac monitor defibrillator gets all screwed up during daylight savings time and can be off by an hour. And it's just amazing that in 2021, that all of our medical devices aren't all synchronized to the national atomic clock, so that we can really figure out what happened during the timeline of the cardiac arrest.
So great comments. I'm hoping that everyone watching the panel will come away with some pearls to kind of help inform not only your decision on what types of technology to purchase and the features and functionalities you'll be looking for, but think about the next steps on how to best implement it and get the most value from your investments in AED technology. So thank you very much, everyone.